Welcome to the Carleena Show, where ordinary people share their hero's journey. I'm your host, Carleena Angwin, and this is episode 25 of the podcast. Today on the show, we have Dr. Kurt Michael. Kurt is a professor of psychology at Appalachian State University, a practicing licensed psychologist, and a crisis intervention and suicide prevention consultant on the national level. Today, Kurt discusses the journey of developing partnerships between the university and rural public schools, a partnership that has offered mental health services to thousands of rural North Carolina students and provided grad students with real-world experience. Kurt also discusses the research that's been done connecting Netflix's TV series 13 Reasons Why with a significant increase in the use of the crisis text line, 741-741. You can visit the Carleena Show website at carleena.net to learn more about Kurt and link to the show notes, which include the Rural School Mental Health Handbook. From there, you can find past episodes, connect on social media, and sign up for the mailing list. Thank you, Stephen Lorca, for video editing and production, so we can post our episodes on the Carleena Show YouTube channel as well as the podcast. And now I bring you Dr. Kurt Michael. So are you a North Carolina native?
No, I was born and raised in Colorado, actually.
Okay, and what brought you to North Carolina?
I did my internship at Duke Medical Center, and so I actually moved. At the time, my wife and I were in Utah. That's where I did my master's and PhD, and then as part of my program, you do a resident internship at another institution, and so I applied all across mostly the East Coast. I applied a couple out west, but mostly East Coast medical centers is where I applied, and so I ended up at Duke, and that's not terribly far from where my wife's family lives in the Shenandoah Valley of Virginia. Mm-hmm. So we wanted to be, had a young family, wanted to be close to some in-laws, and so I guess our selection was to apply to schools, in the Northeast and the Southeast primarily, and then so Duke was the one we picked, and then kind of a funny quick story. My wife's family loves NASCAR, and we were typically going to the Bristol race in Bristol, Tennessee, and we were driving through to go to the race or pick up my son who was with my in-laws, and we drove through Boone, and we stopped for a meal, and we were sitting in there and we kind of looked at each other and said, this might be an interesting place to live. Mm-hmm. And so, back then there were actually payphones. And so I walked back to the payphones. I looked in the phone book, found they had a school named Appalachian State University. I actually cold called the psychology department, and a guy named Stan Asherman picked up the phone and basically just said, hello, psychology, or something like that. Mm-hmm. And so I just said, do you have any jobs? And he says, matter of fact, we're looking for a child clinical psychologist, which I am. And so it kind of went from there. And so I don't know that I really knew much about, certainly not the Appalachian Mountains to any great extent. I had been here previously when I worked in residential treatment, where we used to take kids out in the woods. And some of those places were, in fact, some remote places of the Appalachian Mountains. So I knew about it a little bit, but I wasn't intimately familiar. But, when we came to Boone, it kind of reminded me of Colorado a little mm-hmm. bit. So it seemed to be a good place to put down some roots. And so, we did.
Yeah. And so how long after you started with Appalachia State did you realize the need for the type of work that you're doing now?
Well, I assume just from some of the work in the Rocky Mountain West, where they have, famously or infamously high suicide rates, I figured that was probably the case. And so it wasn't long after I arrived in '99 that I started asking schools to let me conduct some of my research in the schools. And so it was probably around the year 2000 that I eventually was permitted to start collecting some some information about the kids in the schools and began to get some verification that yes, indeed, not only do they have, issues and struggles like the rest of the kids in the country, but maybe combined with the lack of access to resources like mental health care, it seemed like they weren't necessarily that different, but these other barriers were pretty clear: economic, transportation, that seemed to make sense to set up better ways to serve these kids. And so that happened almost immediately when I got here, just from my previous work. It seemed to make sense. And then when I started getting, again, information that were confirming some of my worries, that we started to work more diligently and more deliberately to try to reduce those barriers.
And what did your earlier work look like when you first approached those schools and wanted to offer mental health resources? What did that look like?
So, initially, it's a little bit of a poor fit between what educators have to do, and the list is long, and I don't know that initially the reception to it was that good, understandably, because they're busy educating kids, and a lot of times schools, I think, just if I could make a bit of a sort of a philosophic statement, they're often asked to do too much as it is, and so some of the early reception was not great, partly because here's one more thing that I'm suggesting that they add to their list of responsibilities. And I think some of that early reception was in reaction to that, and just general kind of skepticism. I think understandable skepticism that if we've got to do all this work, when exactly will we fit in the day, working with these kids' mental health issues when we have the entire student body to educate. So really the earliest discussions were about how to serve the needs of the educators and not get in the way of their mission, and trying to explain how removing some of those barriers or impediments, mental health impairments, let's say they were not attending school because they were depressed. So my pitch was, I can provide a treatment that will help improve their attendance just by taking part of treatment. We'll get them back in the building, and they'll be better learners, was really the case I was trying to make. And I guess it really started to get traction when I was at a parent and school meeting. It was probably 2003 or 4, somewhere in there. And so I did an evaluation of this child as a private practitioner in the community. And at the end of the meeting, we're talking about recommendations. And this young man had some pretty significant health issues. In fact, I think he was actually recovering from cancer. And so at the end of my report, I said, so-and-so should receive, weekly psychotherapy services to help support his anxiety and his stress, getting readjusted to school. And so the administrators in the room, including the principal, kind of looked at me like, okay, well, where do we send him? And we all kind of looked at each other, and there really aren't a lot of options in our rural community, certainly not at the time. And so we started having conversations about how we can combine the resources of the university. In other words, we train a lot of these mental health providers in the region, and whether it's in social work or in counseling or marriage and family therapy or in my discipline of psychology. So it seemed to make sense that if we could convince the schools to let us come in, demonstrate its value, bring in students under supervision, we would have people that these families could receive services from, as opposed to just, if you just leave them to their own devices and have them find somebody in the community. Again, it's a fairly limited list of possibilities. And so it was just really trying to build capacity, especially for serving kids and adolescents in a community where there really weren't a lot of options. And so it just seemed to make sense to combine this obvious, push to train the workforce that is at the university, and combine that with all of the substantial needs that were already pretty
Mm-hmm.
clear in the communities and the schools. And so, and it really took, I think, a fairly visionary type of administrator. In this particular case, her name was Angela Quick, actually at the recommendation of my wife, who said, this is who you should talk to. Because a lot of times whenever you try to develop community programs, there's always a need to find champions.
Mm-hmm.
And, certainly my wife was familiar with my frustrations going back to when we first got here. I had a lot of doors closed in my face. And she said, this is who you talk to. So kind of highlighting what we now know to be
Mm-hmm.
identifying champions of something. And if you don't have those champions in place, you're pretty much dead in the water.
Mm-hmm. Mm-hmm. Now, you said that you offered treatment and psychotherapy. Were those psychology students, like was it a master's program or a PhD program, students from Appalachia State who went into the schools and offered these resources?
Yeah, initially it was actually me and some other licensed doctoral level providers. There was a woman in social work, Lauren Rankert, who is now the chair of that social work department. There was John Winnick, who's a marriage and family therapy professor. And so initially it was chiefly me and Lauren who
Mm-hmm.
went in. And when we eventually were able to demonstrate its potential impact, that's when we started asking them, hey, can we bring our students in under our supervision? And they began to slowly, I guess, trust us to be able to do that. And so, yeah, now it's almost entirely the clinical labor is, I would say, 90% the graduate students under supervision in the master's program in psychology, master's program in social work, master's program in marriage and family therapy, and at other sites and other schools,
Mm-hmm.
it's psychology solely in some of these other settings.
Mm-hmm.
But yes, it's mostly masters, and we just started a doc program. I don't know if you have talked to Lisa about any of that, but we started a brand new doc program, which is really just an extension and a natural evolution of our master's program.
Mm-hmm. So, from talking to these students during the therapy sessions, what sort of struggles were they mostly teenagers? Was it a high school or was it middle school also?
So it started in a single high school.
Mm-hmm.
It's expanded to middle school and actually down through kindergarten through middle school as well in some other counties. And so I think it started at the teenage level first, and it's kind of worked its way downward, I think.
Mm-hmm. And what were some of, just to give an example of some of the struggles that the students are going through? What are some things that the students are dealing with?
I think our two, probably maybe three most common issues that we encounter on a regular basis, probably about 50% of our kids are dealing with significant anxiety, whether it's generalized anxiety, could be maybe lesser amount of kids with phobias, obsessive compulsive concerns, depression certainly, and kids who are even suicidal, mostly in thought. Some of these kids get referred to us in advance of, we try to obviously prevent any type of suicide attempt, but we're also there to deal with kids who have made attempts or, let's say, are hospitalized and they're coming back to the schools, and we're trying to help them readjust once they return from some more intensive treatment. But generally speaking, I think about half of the kids we serve have some combination of depression, anxiety, and in many cases, suicidal thinking.
Mm-hmm. And what are some of the root causes of the anxiety and depression, would you say?
It really runs the gamut. I mean, it could be a long-standing, more chronic anxiety concern that they've never had assessed or treated. So again, we try to be pretty specific in what we're trying to address, but it really does run the spectrum. And, we do have kids that struggle with substance abuse issues, conduct problems, discipline problems. Probably makes up the other 50% or so, some combination, attention deficit issues. In terms of causes, it again runs the gamut. It could be a lot of environmental stress, could be trauma, it could be family conflict, So there's a number of things that certainly coincide with what they're struggling with, and certainly a lot of these kids maybe related to their struggles with their mental health ailments, they don't do well in school. So we don't just come in and try to serve those more psychological issues. We try to address attendance issues, discipline issues, even grade performance. We're trying to work, in collaboration with the educators to address all of these particular issues, especially that interfere with school success.
Right, right. And what do the therapy sessions look like? How do the psychology students help the students that they see? What does a therapy plan look like?
Okay, so I'll just give you a couple of I think examples that might help illustrate this. So the model that we use is something called cognitive behavioral therapy. It's something that's been, talked about a lot in the research literature. It's an approach that doesn't just sort of provide supportive counseling. It really tries to target particular behaviors that interfere with, say, someone's depression or anxiety. So here's an example. So if someone is chronically depressed, typically what can happen is they begin to, cease doing things that they previously even found really fun or exciting. And so we employ an intervention called behavioral activation to try to get them to, from a behavioral perspective, start doing the things that they've stopped doing. And typically when people stop, doing things, it tends to allow depression to kind of settle in and be a pretty persistent condition. And so doing things like activity scheduling, which is part of that behavioral activation thing I mentioned, can help kids kind of fight through some of that sort of inactivity that leads to even more of the same. And so we also employ a strategy called cognitive restructuring. We know that certain thought patterns, if left unchecked, tend to rather kind of quietly affect not only the way we feel, but certainly the way we behave. So we try to target some of those beliefs or assumptions that people develop. For example, if they do poorly on an exam and they begin to sort of attribute that poor performance to, let's say, not being smart enough. So a cognitive restructuring intervention would seek to provide a different style of thought. So maybe a different thought would be, instead of I did poorly on that exam because I'm not smart, might be I did poorly on that exam because I didn't really prepare enough. And so you're trying to target changeable behavior as opposed to having this rather permanent belief that no matter what you do, you're destined to fail. And so we're trying to, revise, if we can, some of those core thoughts about why things happen, if that makes sense.
Right, right. And then, at which point in the therapy treatment, do you realize that the student is, they have been helped and they're ready to be released from the program? Yeah, if you could talk about that a little bit.
Yeah, we actually commit to a fairly standard and regular program evaluation, not just overall, but for every child that goes through a complete, informed consent process. So all the parents and the students that we serve are fully briefed on exactly what the treatments are and how we plan to go about evaluating whether it's working. And really, we make adjustments if we're not collecting information on how they're doing. And we do that every time they come in. They basically complete paper and pencil measures so we can keep track of their symptoms and their struggles. And so where we're not making gains, we tend to know that session to session. And when things are not leading to improvements, we're targeting those areas where they're clearly still struggling. So we evaluate literally ongoing, and both along the way and at the beginning, middle, and end of the treatment that they receive. And I would say on average, the kids typically undergo about 3 to 4 months of therapy, and that might add up to 10 to 14 individual meetings, each lasting 30 to 40 minutes, in which they're doing some of those targeted things I mentioned earlier. So we're constantly trying to assess, which kids are responding. Not every child responds. And so those that do not, we either change the dosage of psychotherapy, or in some cases, we decide that it's best for them to seek outside services, either in addition to what they receive with us or even separately. Mm-hmm. So we're always trying to pay close attention to what's going to best serve the needs of this child and family, and refer them if they need something additional.
Mm-hmm. So you started this program, you said, was it 1999?
The program itself didn't formally start until 2006.
Okay.
What I was really describing earlier is kind of the early evolution of it.
Okay.
And some of my research that I was doing in the schools, that's kind of where I got my, I guess, my start. And then as it became pretty clear that there was a need, that's when it took. I mean, kind of really illustrates how things tend to move more slowly than you'd like. Mm-hmm. And so it took me, a good chunk of that time to really get sufficient traction to actually start the program.
Right. Okay. So you started formally in 2006, and it's 2019 now. So what are some of the successes that you've seen, or the growth of this program over those 13 years?
Yeah, I think the biggest thing is just the number of graduate trainees and the students that we've served over the years. And, it used to be a pretty small operation, essentially part-time, one clinician, one principal. And in those early days, we actually had the help of a school resource officer that helped to actually manage some of the more difficult cases. And so it was kind of a motley crew. And from there, it really began to ramp up. And so generally speaking, and we have now 3 different school districts that we serve. And I have another colleague of mine in psychology that's joined the operation. His name is J.P. Jameson. So he's joined, and he runs an entire district's program really pretty much by himself. I do help him a little bit, but he's chiefly there doing the work and supervising students himself. And so it's really grown into 3 different school districts. And I can't give you an exact number of the kids we've served, but I'm sure it's in the thousands.
Wow.
Over the years.
And what is some of the feedback you get from the grad students who are offering this the therapy to the students?
I think the biggest advantage for grad students is, when they're trying to learn how to do this work, sometimes there's this notion that you don't start doing the real work until you graduate. And I think because they're doing this on the way to getting their degrees and eventually their licenses in mental health professions, is that they really, they're doing the work again before they're degreed, which actually makes them pretty marketable once they either decide to go on and just work in the profession or in the field. So they can say with confidence that when they're being interviewed that they actually know how to do cognitive behavioral therapy with clients in the schools, and they tend to learn lessons that they wouldn't have learned otherwise because they're actually already deployed. And so I think that's an advantage. They also talk about those that go on to get PhDs, that the clinical training they get at the ASK centers are they find it to be very helpful, and that it just makes them feel, I think, really prepared to go out and do this work. A lot of it's very difficult. Like, for example, if you have your first encounter with a suicidal student after you graduate, you don't even necessarily know, what your strengths and weaknesses are in that approach. And so under our programs, you get a chance to do that direct work, which can be pretty scary, pretty anxiety provoking. again, well before you finish. And so I think it just improves our clinicians or our grad students' confidence in doing this hard work before they leave.
Mm-hmm. Is your program, is this unique to North Carolina and the Boone area, or are other psychology and social work departments doing this across the country?
Well, I mean, the movement of school mental health is pretty pervasive across the country. I think what's probably not as common is these kinds of partnerships between universities and rural schools. I know that that's not terribly common. For example, we have over 100 school districts in North Carolina, population of 10 million people. And, in terms of the number of partnerships like this across the state, I would say there's probably fewer than 10 that have this kind of approach, and maybe even fewer than 3 or 4 that do this kind of true partnership in schools. And I can't necessarily give you a rundown of places across the country, but it's fairly uncommon to have these kind of partnerships. They're hard to sustain. It's just these are systems that don't always consistently work together, let alone in remote areas. And so I think it's fairly unique. And again, we get asked to talk about it in various places, and the places that can develop these programs are sometimes the breakdown is when they can't develop a sustained partnership between a local university and the school district. I mean, I can think of probably 3 different colleagues in the state of North Carolina that have done something pretty similar. And again, it's one of those things. It's backbreaking to sustain these things, and getting my administrators on the university side to let me not just do my teaching in the classroom, which is more traditional, but letting me do my work, my teaching out in the community. Mm-hmm. And so I'm lucky because I have a university that supports this work, and I can't say that that's always the case for college administrators at various universities across the country, even though they have faculty who are very invested in these kinds of partnerships.
So let's say there's a high school teacher listening to this episode right now, and they think, well, I want to start something like this in my high school. I know that the students could really use this type of therapy. What should they do? How could they get a program like yours started in their high school?
Yeah, well, we actually thought that if we were to do this again, we would have appreciated some kind of central resource of, like a handbook or something that would give you different perspectives on how to develop, implement, sustain, and even fund these programs. And so JP and I, the fellow I mentioned before, wrote a handbook of rural school mental health a couple of years ago. And so I would suggest they get their hands on. I'm not trying to necessarily promote the book, but it may sound like that. But it's a really good resource, and it's got 23 chapters in it, and it's sort of a how-to manual, really. And so we would recommend that anybody who's interested would get their hands on that book.
Mm-hmm.
And
yeah, if you could send me the link to that, I'll add it to the show notes.
yeah, I think it's just there's lots of there's probably 73 different authors in that book, and I think the wisdom among those 73 scholars is pretty significant, and they would have different perspectives, but helpful perspectives on how would you start, develop, and sustain such.
Okay. Yeah. Yeah. So let's talk about the Netflix show 13 Reasons Why. And you've done some research with the correlation between that show and a rise in crisis text line use. Is that correct?
Yeah, we've been looking at that for a couple of years.
Okay. So tell me a little bit about your thoughts, because I watched the show. I think it was last month. I watched it, and I've had sort of mixed feelings about whether that could be helpful or not to teenagers. But could you talk a little bit about your thoughts on that show?
Sure. But before I do, just a question for you. Have you seen both seasons or just season one? Or
I just saw season 1 and I watched the first episode of season 2 and I lost interest, I'll be
okay,
honest. So, but the first season was, I pretty much binge watched it. It was, but at the same time, I'm thinking to myself, is this something that could be helpful
yeah,
or not? Because they really dramatized suicide and revenge and that those sort of themes. So,
right.
so my feelings are mixed.
Okay, yeah, and I think you're in good company. I think a lot of folks see the good and the not so good in the series, and so I'll just summarize kind of what how this happened for me personally. Being a parent, I was hearing that a lot of teenagers were watching it, and so I didn't actually binge watch it until probably a month or so after it was released. I think it might have been a little bit, maybe in the middle of, let's see, I think it was like maybe early April. I started watching it when it was first released. Anyway, so I'm also curious. Did you watch the last? There were 13 episodes in season one, and there was actually an epilogue. It was called Behind the Reasons episode. Did you watch that 14th episode?
No, no, I didn't.
Well,
I
and
didn't know it
that
was there. I'll have to go look that up.
well, even your answer helps sort of even address one of your questions.
Hmm.
So, with the suicide prevention community is a pretty tight knit community, and so around the time it was first released, I was at a American Association of Suicidology meeting in Arizona, and it's a meeting of clinicians, researchers, survivors, people with lived experience who convene every year, and it's been around for 50 years. I mean, it's a very well established group of professionals and paraprofessionals who take the issue of suicide very seriously. And so there was a lot of buzz at this meeting that actually happened right after the release. And so a lot of us are talking, and a lot of us are concerned, we're concerned about the way it was portraying not only the topic, but actually graphically showing in season one, as you recall,
Hmm.
the Hannah actually dying by suicide in by cutting her wrists in the bathtub, and it was, and then her mother walks in. It's a really horrible scene,
Hmm.
and so I think righteously got a lot of criticism for that. What was thought to be by some gratuitous, and so I think for a lot of kids, let's say they watch it alone and they themselves are struggling with something and they don't have anybody to process it with, or they've had a traumatic experience. And because again, the other stuff that's covered pretty clearly in the show are things like sexual assault and substance abuse and violence, domestic violence. So it's a pretty intense show.
Hmm.
And yeah, I suppose if I could sit down and watch the series with my kids, I would do that and I'd want to do that. But not everybody has the luxury or the circumstances that would support that.
Hmm.
So we a lot of us in the professional community became concerned that this could be a very distressing thing for someone who was already vulnerable. Let's say that, and they were not able to process it. That that struck us as problematic. Now, I know in that episode 14 that I mentioned, they did talk about they struggled with whether to show that scene, which was multiple minutes. I didn't put a stopwatch on it, but
Hmm.
it was a lengthy scene. And they talked about should they have done that, and again the producers, I think, to their credit, wanted to you know have this be a conversation starter.
Hmm.
And so clearly that kind of material, although again dramatized and fictionalized, I think that was that's part of the entertainment industry. I mean, so I think they had dual motives. I think they wanted to produce a show that was a hit, and it was.
Hmm.
And I think they wanted to also promote conversations, and I think it's done that too. So those are potentially good things.
Hmm.
But in terms of the other thing I was referring to, like, is it potentially hazardous to depict that in a way, especially for kids who may be vulnerable? And I think we're getting evidence that there are some ill effects of this. There's also the positive side, which is it is starting conversations. And there was a study that was done, and I think I sent you this paper, and it references this study. Mm-hmm. The author team the first author is Ayers, and it was published in 2017, and it really showed that internet searches after the release of season 1 really spiked. And we're talking like a lot of conversations online or Google searches. I think between 1 million and 1.5 million more than expected Google searches that had a variety of search terms like suicide prevention. But on the other hand, kids, we think, or a lot of kids anywhere, a lot of people were searching things like how to kill yourself. So the worry that we have is that it's really showing people, oh, this is how you do it. And, that's certainly not good. Now, we also have evidence that kids that were interviewed right after being hospitalized for suicidal ideation were asked, A, did you watch the series? And B, what were the effects for you personally? I think they interviewed 87 different kids who were admitted to the hospital, and about half said they watched at least one episode of season 1, and half of those, around 20 or 21 of the 87, again, half of which said they watched it, half of the ones that watched it said it increased their suicidal thinking to some degree. And the other thing that we found out is that kids that had higher levels of depression tended to have a pretty negative reaction to some of the elements in the series. So again, we have emerging evidence that there's on the plus side, people are talking about it more. On the negative side, that it's potentially triggering for people. Now, the other thing that happened, the other part of the research that we haven't quite finished up yet, it's research that we're still doing. Mm-hmm. We wanted to find out, because towards the end of season 1, when they were getting a lot of pushback in the media and so on, that is, the series, that Crisis Text Line actually got pretty serious and partnered with Netflix to produce maybe more publicized resources for help seeking, like Crisis Text Line. Mm-hmm. And so, we wanted to know what was the results from that promotion. And I can't talk about the findings just as of yet because they're not published yet, but mm-hmm. we do have some answers about that, and it's actually not bad news. I think what I can say broadly is that we have early evidence that promotional connection between a series that can be provocative and help seeking is on the rise, and I think that is good news. So mm-hmm. you can't necessarily just say sort of it's not a clear yes or no whether there's ill effects or positive effects. I think there's both. Mm-hmm.
Mm-hmm. Do you know if there was a psychologist or a social worker who was part of the writing process of 13 Reasons Why?
I think they had lots of consultants, and if you watch that episode 14, Behind the Reasons or Beyond the Reasons, I think it's called, or something like that. Uh-huh. I think they had several consultants that they worked with, mm-hmm. and I think that's good too. I think there were folks in the community not associated with the series that felt like they just didn't do enough, mm-hmm. and so the fact that they made a pivot and were more deliberate about help-seeking resources. Let's say at the bottom of the screen, before and after every episode was something that they added. I think that's great. If we can really get people to become aware of these resources more readily, mm-hmm. I think it just improves even my ability to work with kids in schools on the ground, because if in between, let's say, their session is not for a few more days and they have this ability to reach out to an anonymous and free and fully 24/7 available service like Crisis Text Line, mm-hmm. I think that's where we need to go.
Mm-hmm. You mentioned that the people in the suicide prevention community said that that 13 Reasons Why didn't do enough. Like, what else could they have done? What else, for example, could a
Yeah,
television show like that have done? Yeah.
I think, like I mentioned, maybe instead of having you know how you said you didn't notice that 14th episode, I think that should have potentially been on the front end.
Mm-hmm.
Or again, before and after every single episode itself, or even, when the credits roll, or even before the show starts, if you're concerned about someone, call this number, or here's the suicide prevention hotline,
Mm-hmm.
and here's crisis text line's number. The more that could have been done would have been promoting and making more visible those resources that we now are getting information back that are not only being utilized to a much higher degree.
Mm-hmm.
If you add up, if you go to the crisis text line website and you see how many text conversations they've had since their inception, I think in 2012 or 13, it's something pushing 100 million. I mean, it's extraordinary. And so I think that's an obvious place where we could do better.
Mm-hmm. Mm-hmm. And with the success, as at least with the number of people who have watched the 13 Reasons Why, there's likely to be more shows and movies that kind of broach this issue. What recommendations or suggestions do you have to the writers and producers of any new show that comes on?
Yeah, I would say, combine some of the uh, promotion of the show information along with the visibility and promotion of those same resources that we've just talked about, and others too. I mean, again, the examples I gave you about even the things that our kids in our schools are talking about. I mean, a lot of our kids, by the way, when we are serving, will mention the series. And again, there's no doubt that these young people are if not flocking to these shows, they're certainly watching a lot of this stuff. And so I think just being a lot more sensitive to the possibility that some of the material can be really pretty tough material and tough to process and handle, that we have to be ready to serve those kids that come to our attention. It's sort of like whenever you're collecting information on kids who have whatever they're struggling with. It's one thing to find out about it, but if you find out about it and then you have nothing to offer them, I think that's a big problem. So a lot of times our philosophy has always been, if we're going to build some type of intervention apparatus, that we want to sort of do some careful assessment, surveys, et cetera, to know what the extent of the problem is before we sort of set out to do something about it. Because what happens if we evaluate, let's say, every kid in a school, and we don't know that, let's say, 20% of the kids are struggling with depression, let's say, just as an example.
Mm-hmm.
That if we're not prepared to learn that answer and then respond, I think that's irresponsible. And so I think anything that could conceivably sort of trigger these kinds of reactions, we have to be prepared to respond.
Mm-hmm.
And so I think any way that these shows set this up, I think they need to be a lot more mindful and purposeful in setting up support systems
Mm-hmm.
at the time of release.
Mm-hmm. Yeah. Is the crisis text line, is that just in the States or is that international?
I think it's mostly a U.S. service. I could be out of the loop, and maybe they are going international.
Mm-hmm.
I think you can access it anywhere you have a cell phone. So I suppose conceivably you could access it in other countries, but I could be completely wrong.
Mm-hmm.
I don't know the answer to that. I could certainly direct you to someone who could answer it, but I know that as long as you have access to that 741 741 number,
Mm-hmm.
that could again, I think theoretically be anywhere.
Okay. And is that a number that people text, or do they call it and actually talk to somebody?
It's actually just it's strictly text interaction.
Uh-huh.
So basically, if you text start or hello to 741 741, basically an algorithm would kick in. And if you say certain keywords in your text, a live text counselor gets dispatched to you. So it kind of has the capacity to just from a technology perspective, it can receive a lot of incoming text calls, and then depending on what you say or what the topic is, that determines how quickly someone gets on the line with you that's live.
Okay.
And they have an incredible workforce of volunteers. I mean, if last I recall, they've got 5,000 to 6,000 volunteer text counselors available. Not at every one time, but the volume is extraordinary, and the training is impressive. And so every person that volunteers is assigned a supervisor. So you can, let's say you get into a situation where you're not sure how to respond to a person, that you can have a live supervisor available to help you through that at a moment's notice.
Okay. Okay. So is there anything else you wanted to mention? Anything else that's important to share with this conversation?
Maybe just that. I think one of your questions had something to do with my kids, and I think you asked something about did they give me important insights, and always. I
How
think
so?
my most important skill is listening, and whether that's to my kids or the kids that I serve in my practice or my students or my wife. I try to be a good listener, because I think if you really listen, I think that's where you're able to create ways to respond. But it only works if you really listen.
Did your kids watch 13 Reasons Why?
Yeah, parts of it. I think they were both somewhat. I want to say bored by it, not impressed by it. And again, I think they were also, they're certainly aware of my work, and they've given me a lot of pretty helpful insights. And actually, my daughter is going into theater and acting, and she's given me a lot of, I think the ability to translate some of the stuff that really, and my son too, what kids say and what it means from their perspective.
Give me an example.
Well, okay. Here's maybe one that might fit. So this is something I talked to my daughter about, for a while, and sometimes there's this sort of, I don't know, myth that kids who are, suicidal or they do something, it's attention seeking. And a lot of times it's a way to, sometimes adults dismiss distress or dismiss something that's kind of scary or they're just wanting attention. And so I think my daughter was insightful in telling me, well, yeah, but that may mean something's wrong, and that may signal something, even more deeply is wrong. And so I think she was insightful in the sense that she said there's no value placed on the attention seeking. It's just telling you something. And so whatever that is really worth paying attention to and not to dismiss it. And so I think that was probably something that she made crystal clear in my mind was, attention seeking or not, it still needs to be attended to, whatever that means.
Right. Okay. Yeah. Is there anything else? Any other bits of wisdom you wanted to share or thoughts?
I don't think so. I think this has been, a pretty gratifying kind of work that I've been doing, and it's hard, but I think it's worth doing.
Yeah, yeah. Well, it sounds like really good work, and I really appreciate you sharing your, the journey of this process, and all the research that you've done with, shows like 13 Reasons Why, and even the insights you've shared with, it being a parent. So I really, really appreciate you and your time, and so thank you.
Thank you.
All right, you take care.
You too.
Bye.